Good evening, everyone. Welcome to Masterclass in Critical Care Medicine from Yashoda Hospitals in association with IFCCM Hyderabad chapter. We have interesting case discussion today again. So topic for discussion is acute necrotizing pancreatitis. To take the case, we have senior examiners, Dr. Pradeep Rangappa sir from Senior Consultant and HOD, Department of Critical Care Medicine from Manipal Hospitals, Banglore. And another examiner is Dr. Sachin Gupta, Director Critical Care Medicine, Narayana Multispeciality Hospital, Gurugram, Haryana. To present the case, we have two final year DNB students, Dr. Rajesh and Dr. Lohitha. Over to you, sir. Pradeep sir and Sachin sir.
Good evening.
Rajesh, you can share.
Yeah, thanks, Shashi, and thanks, Venkat, for having me and Sachin. So I think we'll allow Lohit and Rajesh to present the cases as you would present in exam. And Sachin and me possibly may intervene and ask questions. Is that okay, Venkat, or we let
sir.
them
Yes.
to finish the case and then
No, sir. No. It is from the first presentation. There should be an interaction.
Yes.
So not at the end, sir. It will be with the flow of the case.
Yeah, sure. So I think the case they are going to present, as we are told, is on pancreatitis. So Sachin and me and Venkat possibly will be intervening and asking you any questions or any clarity that we need to have. Over to you, Lohit and Rajesh. Just present normally as how you would present in exam.
Sure, sir.
Sachin, you have anything to say? Sachin?
No, sir. No, sir. Let them go through the case. We'll intervene as and when required.
Stop me the presentation is there. Close it.
So both of you are final year students, right?
Second year.
Second year students, and you have seen pancreatitis patients.
Yes, sir.
Chalo. Good. That makes life easier for everyone.
You can start off, Lohit and Rajesh. You are sharing your screen, is it?
Yes, sir.
They are sharing, sir. I think they are trying to say this.
So we'll open again the document. Go.
What happened? Any difficulty to share the screen? Yeah.
Yes. Good evening, sir. I'm Dr. Rajesh. Going to present case about acute necrotizing pancreatitis. 30-year-old male patient, IT professional by occupation.
Rajesh, bit louder. Come close to the system.
Yes. A 38-year-old male presented with a 38-year-old male IT professional by occupation presented with complaint of pain, abdomen, nausea, and vomiting since 1 day. The patient is apparently all right one day ago when he developed pain in the abdomen, which is severe, sharp, predominantly in the epigastric region, radiating to the back with no aggravating and relieving factors and associated with nausea, vomiting, and a loss of appetite. No history of loose stools, giddiness, heartburn, or trauma. Past history: patient is a known case of diabetes since 2 years on oral hypoglycemic agents, not a known hypertensive, and no history of similar complaints in the past. No history of recent surgical procedures, no history of recent drug use, no history of similar complaint in any other family members. Personal history: he takes mixed diet. Presently, appetite is decreased since last 1 day. Sleep disturbed. Bowel and bladder habits are regular. Patient is a known alcoholic since last 10 years and had a bout of alcohol consumption 2 days ago. General examination.
Can we go back? First slide. So see, the patient presented with very, very vague symptoms, right?
Yes,
So
sir.
tell me the DD just on the basis of these symptoms that you have. The presentation, just tell me the DD.
Pain.
What all should come in your head?
Yes, sir. Pain abdomen along with nausea and vomiting and a loss of appetite. Initial will be any acute gastroenteritis, sir, or any peptic ulcer disease, or if the patient had any reflux or esophagitis condition. And then if there could be
This is only one day. Remember, we are
Yes.
talking about a one day history. So we
Acute
will not put any DD which is more chronic in nature, right?
Yes.
Gastroesophageal reflux disease is not going to happen in one day,
Yes, sir.
right? So let us talk about acute issues.
Yes, sir. It could be cholecystitis, sir,
Right.
or cholelithiasis, or any appendicitis, or pancreatitis. If there's any ischemic causes like mesenteric ischemia.
Again, for mesenteric ischemia, these are not the symptoms to start with.
Sudden onset.
As you rightly said, acute gastroenteritis should be your first DD. Appendicitis, cholecystitis, any other thing? Any other thing? Non-abdominal cause? Look at a non-abdominal cause.
Even your myocardial infarction.
Exactly, myocardial infarction, right? So just by symptoms, we should have 5-6 DDs, and then as you go on, you will be able to rule in and rule out, right? You have already written no history of loose stools, giddiness, heartburn. So gastroesophageal reflux disease is actually, out just by the symptoms itself. Okay, go to the next slide.
Even renal colic is something you can think.
Right, sir. Renal colic.
Young patient, sudden pain.
Go to the next slide, please. Okay, now looking at this history. So certain points which I would like to correct. In the last line you have written had a bout. Bout is not the correct word when you're looking at acute alcohol consumption, right? Bout is not the correct word because you will be presenting this kind of history, right? So it could be consumption of alcohol. It could be binge alcohol consumption rather than a bout. Bout is as if you're vomiting. Bout is it has a different terminology, right? So don't use that word bout. Now looking at this history, any other DD comes to your head?
Any
Now
esophageal
looking at
tear,
this history.
post vomiting, any esophageal tear, or diabetic
else?
ketoacidosis.
Sorry?
Diabetic ketoacidosis, sir.
Yes, diabetic ketoacidosis. Absolutely right. So diabetic ketoacidosis is one more DD here because patient is a known diabetic and ketoacidosis can present as abdominal pain, nausea, vomiting. See, they're all vague symptoms. Right. So want to add anything?
No, I think that's
Rangappa,
that's good DD. Yeah, I think that's fine. I think they can continue.
That's fine. Okay. Now let's move on.
General examination. Patient is conscious, coherent, cooperative, is moderately built and nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Patient is temperature of 100.4 degrees Fahrenheit and heart rate of 125 beats per minute and blood pressure 110/70 and serum saturation of 92% and respiratory rate of 30 and pain score as visual analysis scale 8 out of 10.
So Rajesh, just in examination, just go back to that slide. So generally, why do you ask for clubbing? Is there any correlation to the symptomology that you're looking at or lymphedema, or it's just as a routine narrative you are telling us that there's no lymphadenopathy, no clubbing, no pedal edema? Or is there any correlation to the patient's presentation that you're looking for clubbing, you're looking for or cyanosis? Or is it just a routine rant that you're giving us?
Usually in chronic presentation, we can know how systemic involvement is there, sir, with clubbing or lymphadenopathy. If there is any mass lesion in the abdomen or malignancy suspicion, then patient can have clubbing. That is one of the cause. Lymphadenopathy, even generalized lymphadenopathy or any mesenteric lymph node involvement, that also could be one of the presentation as a pain abdomen in these patients.
Can you go back to your previous slide? There is a history here which can have a couple of findings which you said no. There is history here.
Yes, sir.
What is that history? When you are saying patient does not have clubbing, cyanosis, lymphadenopathy, pedal edema, by the history itself patient can have certain findings.
Uh,
Can you see on
not
this
a
slide?
chronic condition, sir.
Patient is a known alcoholic since last 10 years,
Yes, sir.
right? So you don't know about the liver disease status of this patient. Now go to your next slide. So your liver disease patient can have clubbing. Your liver disease patient can have pallor. Your liver disease patient can have pedal edema.
Yes,
Yeah,
sir.
Right?
possibly that's a right way of describing Rajesh and Lohit. If you had told me that possibly you're looking at any liver involvement considering his ethanol, then it would have given a good perspective to why you're asking. But other things you said possibly did not really convince us that you were really looking for any malignancy from the history given, isn't it? So what maybe me and Sachin would like to know is if you're asking something, it should be in the context of the clinical presentation and some logical thought process that is coming into your mind. Otherwise, these are all routine things which at an MBBS level we keep telling no pallor, sinuses, no on all these. But at your level, we want to put into a context and make some assessment as to logical thought process that is ideating in your mind.
Yes.
Right? So whenever
Sachin,
you say something, there has to be a reasoning for it. Right? Okay. We can go to the next one.
So the general examination, just going back, Lohit, does that indicate to you that this patient is very sick and needs ICU because you are an intensivist? So my immediate question is, looking at those general examination findings, what is your assessment? That patient is very sick, needing ICU admission, or what are your thoughts looking at these general examination findings?
As such, patient need not have an ICU admission, sir. He is tachypneic, tachycardic, and room air oxygenation maintenance is around 90 to 92%, but he'll be needing a high dependency unit observation for continuous monitoring.
How do you decide whether a patient requires ICU or not? Is there any parameter?
Yes, sir. Based on how his conscious level is, how his breathing is, if there is any respiratory distress, or if there is any high oxygen requirement, or if it's hemodynamically unstable.
So are these only subjective findings, or there are any objective criteria?
We have some scoring systems also, sir, to consider. What we initially for pancreatitis, we have a bedside.
We don't know whether this is pancreatitis.
Yeah.
We still don't know.
Yes, sir.
Now, just by this, will you
also
admit this patient or not in the ICU?
No, sir.
Okay. Do you still follow the Q so far, or is it out?
We consider, sir.
We consider what are the
Modified
components of Q
sequential.
so far? What are the components of Q so far then?
Altered consciousness, sir, hypertension, and increased respiratory rate.
So does anything fit into it?
Yes, sir. He is conscious oriented, but he's tachypneic, and he's maintaining blood pressure of 110 by 70 millimeters of mercury. So the Q so far score is 1. More than 2, he'll be needing an ICU admission.
Okay.
Okay, you can move forward.
Stomach examination, gastrointestinal system, inspection, abdomen is distension, no visible organomegaly, no scars, sinuses, dilated veins, no visible peristalsis, and all hernial sites are normal.
How did you do visible peristalsis? How did you see the visible peristalsis? From where did this word come? How did you assess the visible peristalsis?
And even no visible organomegaly, that looks very gross, Rajesh. Because gone are the days people are so emaciated that you can see a big spleen, big livers. So I think, see, these words possibly should be avoided at your level because these are something which we don't realize, isn't it? These are all very subjective. No visible organomegaly sounds really gross.
And this is very primitive. See, this is very primitive. As sir rightly said, this is, if you are doing an MBBS, yes, these words make sense. You are super specialist. So we have to be more specific in what we say, right? Don't make it a generalized presentation. So the couple of lines, no visible organomegaly, no visible peristalsis, you will not be able to explain what you're writing, right?
Yes.
Okay, we can move forward.
Palpation, abdomen is distended, tenderness in the epigastric and periumbilical region, no organomegaly, no fluid thread. On percussion, tympanic nerve is heard all over the abdomen.
What is the significance of no fluid thrill? Why did you check for this in this particular patient?
For SCTs.
If
Sorry?
Actually, we'll check for the fluid thrill if there is any shifting dullness, sir. On percussion, if we get a dull note, then we ask the patient to turn to the other side. Shifting dullness is present, then we consider so that if it is transmitting or not.
What is the significance? What does it interpret? What does it tell you?
Yeah, honestly, Lohit and Rajesh, have you done fluid thrill in any patient recently in ICU?
In the recent times, no, sir.
Then
we
why
do
are
it?
you mentioning all this which is not commonly done? Because you see fluid thrill in a massive ascites, not in someone with pancreatitis presenting acutely. And there is a way that you do fluid thrill. And if you mention this, me and Sachin would upfront know that you have not done this, honestly. Isn't it? You yourself are telling you have not done it for last few whatever. So you wouldn't have done. So you are just mentioning something that you have not done, isn't it, Lohitha? So be honest to yourself when you're presenting, because we can immediately know whether you have done it or not. Because fluid thrill is not something you would do in an acute abdomen.
Right. Okay. Move forward, please.
On auscultation, ball fronts are sluggish, respiratory system normal, vascular plus sounds are present, and no added sounds are present. Cardiovascular S1, S2, and no murmurs.
So just go back. Just go back.
Just go back. See, in ICU, I don't know, S1, S2 heard. That looks like very monotonous presentation, Rajesh. See, we want it to be very guided presentation and guided sort of examination. Why would you want to tell at your super specialist level S1, S2 heard? That is at an MBBS, it's okay. We understand that. And murmurs, I don't know if it has any relation to this patient. Wheeze is okay because sometimes pancreatitis, because of increased intra-abdominal pressure, they can have sometimes wheeze, blah, blah, blah. But so I think avoid all this general rhetoric, I would say, where you come out with just general statements. It doesn't make sense to this patient at our level, because as an intensivist, we would not want you to present some routine rhetoric of any case. We want to just get into the perspective, present some leading sort of a pointers or clinical signs, which will help us ascertain the severity and possibly help in guiding and establishing the diagnostic elements. Sachin?
So, yes, sir. I would have loved if you had written, because see, your saturation was 92% on room air, right? Somebody who is an healthy individual, 38-year-old young individual, should not have 92% on room air. So just by writing normal vesicular breath sounds, you are not evaluating why this patient has 92% on room air. So are there any findings posteriorly that has to be mentioned in your presentation? Secondly, this patient is tachycardic, 125 heart rate. You cannot write S1, S2 heard, no murmurs. Even if you want to mention your CVS, then you have to write tachycardia present. Right? You just cannot have a normal cardiac presentation. This is not a normal cardiac presentation for this patient. So V's or added sounds, yes, I agree that can be mentioned, but always evaluate in terms why this patient is having this particular finding. So somebody will not have 92%. This means there has to be either basal atelectasis. If I'm just going by the case itself, it has to reflect in your auscultation findings. So it's an incomplete information that you are giving us by auscultation.
Okay.
You can move forward.
Okay, right.
Yeah.
We can move forward.
And even the temperature.
Okay.
On day one, the temperature is has a temperature of 100.4 degrees Fahrenheit. Patient is tachycardic and tachypneic. And room air, the saturation is around 92%, and the pain score on visual analog scale is 8 out of 10. ABG is acceptable with pH of 7.6 and PCO2 of 29 and bicarb of 20.5. No acidosis or with a mild respiratory.
Okay.
Labs, labs hemoglobin is 12 grams per deciliter, hematocrit is 36, and total leukocyte count is 8,000, serum creatine 0.7, blood urea 5.14, and blood sugars are 240 milligrams per deciliter. LFT came out within normal limits. Serum MLS is 832 units per liter, and serum lipase 950 units per liter, and a BISAP score is 1. The USG abdomen showed a suggestive of acute pancreatitis with no hepatomegaly or gallstones or the GB sludge. Patient is managed with initially managed with IV fluids at the rate of 5 ml per kg per hour, and patient is kept nil by mouth, and IV antacids, antiemetics, and IV opioid for IV opioid analgesics and insulin therapy.
Okay. So a lot of questions here. Please interpret the ABG.
pH, first you look for pH, sir. pH is 7.46, and you look at the direction of a bicarb, PCO2. PCO2 is 29.5 mmHg, which is in the pH is going up, and the PCO2 is in the opposite direction. And the bicarb is 20. So pH is on the alkalotic side with bicarb of 20, which is normally around 24, and base X is -2. It is showing a metabolic acidosis with a respiratory compensation. And lactates anion gap is within normal limits.
So first tell me, is it a respiratory cause for alkalosis or a metabolic cause, or is it an overcompensation of respiration?
It's an
Let me again ask you the same question. Is it respiratory alkalosis and that is the reason the bicarb is less, or is the bicarb less, that is the reason patient is having tachypnea? There are two different ways of interpreting the ABG, right? So you have to tell me, is this primarily metabolic cause or is this primary respiratory cause for alkalosis?
It's primarily metabolic cause.
So initially we look for the pH. If it is in acidotic range or in the alkalotic range, then we'll see the PCO2 and the bicarb levels. If our PCO2 is on a decreasing end, that is less than the normal range of 35 to 45, that indicates alkalosis. And if our bicarb is less than the normal range of 24 to 26, that indicates acidosis. So to consider in this, the PCO2 and the bicarb are in the opposite direction, sir. But our pH is an alkalotic set. So primary will be a alkalotic condition, sir. For the patient to... Sir?
This is primarily respiratory alkalosis which is happening. And that is the reason your bicarbonate is getting on the lower side. The kidney function as of now is normal, right?
Yes, sir.
So let me put you in another scenario. If somebody is having a neurological issue,
Yes,
right? Forget about this case.
Yes.
And he's tachypneic, his PCO2, let's say, comes down to 13, 14, 15.
Yes, sir.
You will start seeing base deficit of 10, 12, right? That does not mean that the patient is having metabolic acidosis. This is a reverse compensation which is happening.
Yes, sir.
And why is this patient having respiratory alkalosis?
It's because of the hyperventilation.
Why is that happening? Why is he hyperventilating?
Because of the systemic response.
Because of the pain,
Pain.
right? Because of the pain, because of the temperature. You have said 100.4
Yes.
degree, right?
Yes,
So
sir.
pain, and this is causing him tachypnea, and that is the reason you are seeing alkalosis here, right? Rest all is okay. I don't want to ask anything on the gas. Now tell me the significance of amylase and lipase. Why did you mention these two numbers?
As a part of evaluation of pain abdomen, we'll be sending our routine investigations and young patient acute presentation. So to rule out pancreatitis, we'll be sending the serum amylase and the lipase values, sir.
What are the normal values? How do you know these are abnormal? Okay, fine. tell me the DD for raised serum lipase.
Even in renal disorders, lipase will be elevated, sir.
Anything else? What happens in paralytic ileus? What happens in mesenteric ischemia? Okay.
Intestinal obstruction related cases also lipase will be elevated.
Right. Any other importance of lipase and amylase apart from, so these are the first values. When will you repeat these numbers?
We
Is
need
there
not
any
repeat,
significance
sir.
of that? So
We
they do
need
not
not-
have any prognostic value,
Yes, sir.
right?
Yes, sir.
They do not have, so you need not repeat these numbers. Yes, they are elevated. They are more or less pointing towards pancreatitis. That is the only significance,
Yes, sir.
right? Which is the first one to get elevated, amylase or lipase?
Lipase, sir.
Which is more sensitive, amylase or lipase?
Lipase is more sensitive and specific, sir.
When will that get elevated? What day of the disease will amylase and lipase get elevated?
Amylase will be elevated in approximately about 6 to 12 hours, sir. But for it to reach peak, it will take about 2 days, 48 hours. Lipase
you-
will be elevated in the initial 4 to 6 hours, and its peak value will be within 12 hours.
Any other test apart from amylase and lipase that tells you about pancreatitis?
In routine, we'll be performing amylase lipase, sir, but we can also send for urinary trypsinogen also, sir.
Any other urinary
Trypsinogen.
test? Yes, urinary. When does it get elevated?
It is also elevated within the initial 24 hours, sir. In the dipstick value, we can know if it is positive or not.
Okay. What is bicep? Sir, you can ask.
Yeah.
Sir, Rangappa, sir, you
So
can.
in
I'm just asking.
yeah, that's good. So in investigations, is there any value for BUN as any indicator? Is it something that indicates that it is a mild pancreatitis or moderate or severe? In the investigation so far you have shown us.
Our mild, moderate, or severe will be based on our any local or systemic complications or organ failure, sir. As per the recent evidences or the guidelines,
No, forget that. I'm just asking you on the labs.
prognostic marker, sir.
Lohitha,
Leduria nitrogen is more used as a prognostic marker, and its elevation or its reduction more than 5 is considered if the patient is responding to our clinical is responding to our therapy or not.
how does that guide BUN as a tool to guide your therapy?
After we start the patient on resuscitation, if our blood urea nitrogen decrease more than 5 gram per mg per dl, that is also one of our goal to consider, sir. And if there is persistent derangement of the blood urea nitrogen indicating that the renal involvement, the patient prognosis will be a bad prognosis.
Okay. I think Sachin asked you about bicep.
Yeah,
Yes.
what is bicep?
It is a bedside index, sir, for us to evaluate for the severity of the acute pancreatitis. It indicate we'll be considering few tools in it. That is our blood urea nitrogen levels, if there is any impaired mental status, or if there is any systemic inflammatory response, or taking patient age into consideration of more than 60 years, or if there is presence of pleural effusion. It helps us for prognostication and also clinically on a bedside to understand how the patient is responding or he's deteriorating clinically, we can know, sir.
So what is the value of bicep? So if let us say you have a bicep of 1, bicep of 3, or bicep of 4,
Yeah.
how does it, what is the prognostic significance of bicep?
Bicep of more than or equal to 3 indicates that it is the prognosis is bad, sir, and mortality also intenses.
Can you just repeat that? Bicep of?
More than or equal to 3, sir.
Okay.
Okay. You said ultrasound abdomen suggestive of acute pancreatitis. What findings were there which was suggestive of acute pancreatitis? What all can you get in an ultrasound abdomen which suggests that the patient has acute pancreatitis?
Edema of the
Sorry.
edematous pancreas.
Okay. Anything else?
We can know if there is any collection, sir, inflamed or edematous. We can know if there is any necrosis, or we can know if there is any peripancreatic collection. And
Necrosis. How
also,
will you come to know about necrosis in an ultrasound?
No, sir.
Anechoic.
CT.
So there can be peripancreatic.
Peripancreatic collection, we can know, sir.
It could be fat stranding. It could be, as you
Peri-
rightly said, fuzzy margins, blurred margins,
Blood.
right?
Yes.
Collections very early. This is very early period for collection. So you may even not visualize pancreas sometimes, right? So there are certain findings which are suggestive of this. So you said no gallstones and patient is managed with IV fluids and okay. Okay, go to the next slide, then I'll see what is to be asked here. Just go to the next
Just
slide.
to ask, is ultrasound good enough to prognosticate the severity, Lohit, or we have better tools? Because I think the trend is towards more radiological prognostication now. So is this good enough information for time being, or you would consider some other investigations later on?
For prognostication, we have scores, sir. Ultrasound abdomen in the initial we'll do to know what is the etiology. Whatever diagnosis differentials we have, what is the cause for the pain abdomen, it will help us to know, sir. Like if the patient had any gallstones, any cholelithiasis or cholecystitis. As such, it might not help us, or in any prognostic severity scores, it's not useful.
At this stage, you mean to say it's mainly for diagnostic?
Yes, sir. In the initial presentation for the to know the etiologies.
Okay, can move on.
Okay.
So just go back. You've written that is the treatment you have initiated. The patient is managed with IV fluids at 5 ml per kg per hour. So that's the treatment initiated, or
Yes, sir.
IV antacids, antiemetics, and IV opioid analgesics and insulin. So that's the initial treatment on day one that is initiated, is it?
Yes, sir.
Yes, sir.
Conservative.
So you said 5 ml per kg per hour. So let us consider this to be a 60 kg gentleman. So we are saying 300 ml per hour, right?
Yes, sir.
Okay.
Yes.
Why? Why such a
Figure 5 ml per
volume?
kg per hour. Is there somewhere reference that that's the amount of fluid we need to give?
Evidence, the guidelines is that for a pancreatic patient, the treatment is fluid resuscitation, sir, only aggressive. But before that, we have to see how the volume status of the patient is there. If he's hemodynamically stable or not, hypovolemia is there.
No,
or
we'll
not.
talk about this case, Rohita. The
Yes.
theory, let's not discuss the
This
theory.
patient
So this
is,
patient hemodynamically stable, saturating at 92%.
yes,
And the investigations reveal to us that he is not hugely fluid deficit, isn't it? Blooduria is okay, hematocrit is okay,
yes,
and his hemodynamic status is okay. Is
yes,
tachycardic, that we would attribute it to pain. Okay.
yes,
So given this scenario, are we justified in doing 5 because you are an intensivist, 5
yes,
ml per kg you initiate,
yes.
or would you do some assessment to consider this number as a therapeutic goal?
No, after we got the patient, we checked for the IVC fluid status, sir. Later, we gave her a bolus of
So
5 ml.
is that something that we need to assume that you have done all that, or we need to hear it from you that you have done this to ascertain this fluid requirement?
We've done the IVC assessment, sir, to know the volume status and the fluid responsiveness. And then we've initiated this 5 ml per kg per hour. We've given a bolus dose, and then we came down to 1.5 ml per kg per hour, sir. We continued and maintained on IV fluids, sir, for this patient.
Is the IVC validated in distended abdomen?
Ideally, yes. It is not
And
accurate.
even Rohita, we do a fluid responsiveness. The type of fluid we give, is it as an infusion or this is a bolus you are giving? Because you are written 5 ml per kg per hour, which means our assumption is that you are giving it as an infusion.
We
Unless you tell us, we wouldn't know what you are exactly thinking.
okay. We gave a bolus followed by we continued an infusion, sir, of 1.5 ml per kg per hour. We didn't
And bolus,
mention
so
it
you have
to
given mini
initiate.
fluid bolus. For my understanding, 300 ml
Mhm.
is what you have given as a bolus. It's sort of mini bolus. Is that something we routinely do at the outset? Maybe we will consider in some situations, but in this, why would you consider a 300 ml as a bolus? That
He's
sounds
not,
little surprising.
he's he's tachypneic, tachycardic, so he'll also have fluid loss also, sir. So once after we got the patient, we assessed again for his fluid status, and then we gave him a bolus.
What is your bolus? What is the bolus you give?
We took like 5 ml per kg per hour, sir, for the initial bolus, and then we maintained him for 1.5 k.
That sounds very
ml per
bizarre
kg.
to me. 5 ml per kg as a bolus. Sachin, your thoughts on that?
For a
Is
pancreatitis
there any reference number, any guideline, any RCT which says that this should be the number? Are you
guideline,
aware of recent trials which have been done on fluid resuscitation in pancreatitis? There is a Spanish trial which was done recently.
yes, sir. Guidelines suggested of 5 to 10 ml per kg per hour, sir.
Hmm.
And there is also trials for aggressive as well as for moderate resuscitation, goal-directed resuscitation.
Yes.
This patient is not hypovolemic, or this patient was not very much in fluid deficit. So that's why we took 5 ml, and then later we gave him only on maintenance fluid, sir. That is, we took on a lower limit value to give the bolus.
What was the result of that goal-directed versus moderate resuscitation? Are you aware?
Yes, sir. Once they started this randomized control trial, the waterfall trial, they compared both this aggressive as well as goal directed, sir. But eventually, when the trial was ongoing, then they had many patients who landed up in fluid overload, and there was no mortality benefit.
There was
in
no
these
mortality
patients.
benefit, and that's the reason they concluded that the aggressive goal-directed
Okay.
fluid therapy is of no benefit, and it does not even halt the progression of acute pancreatitis, right?
Yes.
Okay.
Yes.
Why did you keep nil by mouth? Why?
He was tachypneic, tachycardic, sir. So initially we wanted to maintain him, and he's a case of pancreatitis. So we gave a fluid resuscitation. We initially gave him clear liquids, but he was not tolerating that clear liquids also. So we kept him nil by mouth until our the initial resuscitation.
Okay. IV antacids. Okay. Antiemetics. Okay. IV opioid analgesics for pain and insulin for your blood sugar. Okay. Let's move on to the next one.
And due to the tachycardia and tachypnea was persisting, there are also high-grade fever spikes, and there is a abdominal distension is persistent, and the total leukocyte count is 18,000, and the peripheral spinal leukocytosis, no toxic granules, and the serum creatinine was 0.6, and the blood urea was 27, and urine output is adequate, maintaining at 0.5 to 1 ml per kg per hour, and the serum calcium is 6.8 milligrams per deciliter, and the IVC guided fluid resuscitation patient was done, and patient is managed conservatively with IV fluids, IV opiates, and antacids, namedics, and electrolyte corrections was done.
You did not do CRP in this patient, right?
No,
You
sir.
did not mention CRP.
No, sir.
Okay. Any significance of CRP if you are thinking about pancreatitis? Does it have any prognostic value?
Yes, sir. CRP also has a prognostic value, sir.
What is that number?
More than.
Is there a number to see?
Yeah.
The 150 milligrams per deciliter.
Yeah. Good.
Okay, good. 150. Okay. 18,000 TLC, leukocytosis, no toxic granules, serum calcium is 6.8. Now let us say fine, you have diagnosed pancreatitis in this patient. Tell me the causes of pancreatitis that you think are relevant in this particular patient. That could be the cause of pancreatitis.
Alcohol, sir.
Okay. Anything else?
In this patient, alcohol is the etiology that is relevant, sir. We've ruled out the gallstones, that is one.
Anything else?
And the othermost one of the cause is hypertriglyceridemia, sir, but those were not sent in this patient.
Anything else?
Diabetic patient.
Anything
Any
else?
drugs? Any drugs?
Yes.
Not on
Drugs.
any drug. There
He's
is
on
no-
OHS. You said he's on OHS.
He was on oral hypoglycemic drugs, sir.
Any of those drugs can cause pancreatitis? Are you aware of any group of OHS that can cause pancreatitis? Okay.
Sulfonyl.
Why did you send serum calcium? Why only serum calcium?
It's a
Any
From-
particular reason for sending serum calcium?
persisting symptoms, sir, and also patient pain did not subside, and serum calcium is also a prognostic marker.
How?
Hypocalcemia is associated with
Hypercalcemia can also be one of the cause for pancreatitis, sir. Or in a pancreatitic patient, as the patient from the time of onset of symptoms, as the patient is worsening, there will be saponification and there could be decrease in the calcium values.
Yes, that is the reason. That is the correct answer. Most of the pancreatitis patient will have hypocalcemia because of saponification, right? So we will have to replace this calcium to a particular level, right? Obviously, you will have to know the albumin levels to look at your, corrected calcium levels and all that stuff.
And Lohita, is it part
Okay.
of some
Pain relief.
criteria,
Let us talk-
prognostic criteria? Calcium as a variable?
Yes, sir. It is also included in our Glasgow scale for the pancreatitis, sir. Prognostic scale. That is one.
And what level is taken? Any
Glasgow
level
scale.
less than 8. Less than 8. Both Glasgow and Ramsay's.
Yes.
Okay.
Okay. Now let us talk about pain relief. So you have given opioids, right? Any
Yes,
other drug that can be given? Which one? If not opioids, any other thing?
I think there is a question in chat also on opioid pain management. Is there any study with any other drugs that are used in pain management?
Do you use NSAIDs?
no, sir.
No, sir.
But they can be used. There are studies which have said both are equally good, right? You can use NSAIDs or opioids as well. Anything else? If not intravenous, can we use epidural analgesia?
Yes, sir.
We can use epidural analgesia also. Okay, fine. What about feeding? Is it coming in the next slide?
Yes, sir. Yes, sir.
Have you kept our NPO until day 2 right now as we see?
When will you start feeding these patients?
Ideally,
No, sir is asking, is the patient still NBM
yes,
on
sir.
day 2 also?
We are trying to, when you try to feed with oral liquids, patient is still having intolerance due to severe abdomen pain and vomiting, sir.
Okay.
So there are like mild pancreatitis, you can give initiate early oral feed, sir. If there is vomiting and all, you can put an NG tube and start NG feeds. if there is intolerance.
No, so did you put NG tube in this patient? Will you prefer putting an NG tube in this patient?
He is now in mild category only, sir. Oral feeds is better than the enteral nutrition, but oral feeds he was not tolerating. After we initiated of clear liquids, he complained of even more pain, and he had episodes of vomiting also. So we continued NBO for this patient, and we continued with IV fluids, sir.
Okay.
Is there any benefit
Fine,
of
go
early feeding in pancreatitis, Rajesh? Or is it just that we all like to feed early in all ICU patients, so that's why we want to feed early?
There is
Are there any studies to show there is benefit in early feeding in pancreatitis?
yes, sir. There are studies showing there is the early feeding reduces the rate of infections, reduces.
So that is in general ICU patients. In pancreatitis specifically, are there any studies?
Recently, the Dutch trial.
What did they show?
They showed no difference. They fed with initially early with 24 hours. Within 24 hours, they compared tube feedings, NG feeding, and after 72 hours, there is also oral feeding, sir. There is no difference in mortality or infections in the severe acute
So
pancreatitis.
there is a Spanish trial also which looked at this early feeding versus that conventional practice of waiting till the biochemical parameters and other parameters became better and then the patient were fed. So the early feeding group had a shorter hospital stay. They had a lesser incidence of complications. So the early feeding group always does better, and it is not only for pancreatitis, for general critical care also, but very specifically for pancreatitis. If we are looking at mild cases, early feeding should be practiced as a dictum.
Yeah, I think Sachin is right. So basically these studies, although they did not show primary endpoints to be significant, but in the secondary endpoints, the length of stay in the two studies recently done, both showed reduced hospital length of stay. And even there were two meta-analyses which showed the shortened length of stay with early feeding. This is only in pancreatitis specific. So like in ICU, we believe early feeding is good. Even in pancreatitis, it is shown within 3 days you feed. I think the outcomes with the length of stay is much better.
Okay. We can go to the next slide.
On day 3, patient become drowsy but he's arousable and requiring 2 liters of oxygen to maintain saturation of greater than 94%. There's also new onset hypotension. IVC assessment was done, and IVC guided fluid resuscitation was done, and patient was started on NORAD to maintain MAP more than 65. An assumption there is still abdominal distension, diffuse tenderness, and bowel sounds are present. He's maintaining urine output at around 0.5 ml per kg per minute, and his bicep score is increased to 3. And there is total leukocyte counts increased to 20,000. Serum creatinine is at around 1, and the ABG is showing normal anion gap metabolic histosis with a lactate of 1.5. So blood cultures were sent, and patient is started on antibiotics, Europe and 1 gram IV TID, and other supportive management like antiemetics and analgesics and continued.
Okay, so first of all, why bicep has become 3?
There is a alternate, like the patient became drowsy, sir. There's a change in the mentation, and there is a X-ray showing a minimal left-sided pleural effusions.
It is not mentioned anywhere, right?
Yes.
Okay. Okay. Why did this patient have hypotension? What is the DD for that?
Two causes, sir. One could be as a part of the pancreatitis worsening, and the other could be if there is any new onset sepsis related hypotension.
Sepsis of
Pancreatitis only, worsening of the pancreatitis, infected if there is. Then
do we have infected pancreatitis on day 3 of the illness?
No, sir. That is highly low chances, sir. More common is pancreatitis resulting in a hypotension because of the hypovolemia. That is only the more common cause because of the systemic inflammatory response.
Okay. So it could be just a systemic inflammatory response leading to hypotension, right?
Yes, sir.
Okay. You started on meropenem.
Yes,
Why
sir.
meropenem?
Patient was not any clinical. There was despite of adequate resuscitation, patient was not clinically improving, sir. His there is involvement of multiple organs. There is like in drowsiness. He started requiring oxygen requirement. There was new onset hypotension. With this, though this is a part of a CIRS response, inflammatory associated also, but with a suspicion of infection, antibiotic was started. Sir, we do not have any evidence as of now.
Hmm.
Is there
Why
any way you could have determined if there is an infection, Lohit, rather than starting preemptively? Did we have any other tools to recognize?
CT is done. We are worsening. CT scan is done.
We got an imaging done, sir, on the third day.
Okay.
Okay.
We did not. Ideally, we have to be sending the markers, sir, but in this patient, procalcitonin was not sent. Procalcitonin or the CR.
Okay. And why meropenem? Why not any other drug? Why did you choose meropenem?
High chances of infection is low, sir, but we choose drugs for which have better pancreatic penetration.
Good.
So why we
Now
choose?
tell me other drugs which have pancreatic penetration.
Yes, sir.
Tell me other drugs which have
Other-
pancreatic penetration.
Vinolones, sir, carbapenems are fluoroquinolones and
Third generation.
third and fourth generation cephalosporins.
So why were they not started? Why directly meropenem? Why can't we start third generation cephalosporin along with the fluoroquinolone if you want to give it?
Fluoroquinolones.
We could have started it, or was there any contraindication?
There was
We could have started it.
There was no contraindication in this patient. There was no contraindication for any
No
vitamins, sir.
Okay. Sir, anything, or should we move?
Yeah. So why do you think patient is getting acidotic here? Because lactate you written as 1.5, bicarb is 8. And what is the reason for acidosis here?
He is in normal anionic of metabolic acidosis, sir.
Okay, so the rationale is he still deficit in fluid. Is that the thought process in your mind?
No,
It's adequately
we adequately resuscitated him, sir.
Okay, so what is the then cause for this ongoing acidosis, and how do you want to address this?
It could be because of the resuscitation, also hyperchloremia related non-anionic metabolic acidosis.
So
They-
you have used the saline as a resuscitation for this patient?
Yes, sir. We use 0.9% normal saline.
So is there any study to indicate in pancreatitis that there can be alternate fluid which may be better than saline?
Studies were there which compared balanced crystalloids, ringer lactate along with 0.9% normal saline. But the studies showed almost similar benefits, sir. In the studies also showed in few patients who were resuscitated with the ringer lactate, the worsening was relatively less in those patients, the worsening of the clinical condition.
I think there was a good study. It was a good randomized controlled trial which looked at normal saline and ringer lactate. And even here, primary endpoint was they looked at SIRS. So SIRS, there was no difference as a primary endpoint, but the secondary endpoints, they did show good benefit with ringer lactate. So they did show length of stay was significantly less in ringer lactate, and even the necrosis, progression of pancreatitis to severe also was lessened. So
Yes.
possibly, and even there was sort of suggestion towards preferring ringer lactate in pancreatitis, and exactly more maybe to circumvent this problem also of hyperchloremia, what you are suggesting. But that's a good study. It came in 2021 by US authors.
Yes.
Okay, we'll continue.
Okay, next slide. Next slide, please.
View of worsening, there is a CT, so contrast CT is done, which showed a necrotic pancreas and inhomogeneous collection in the peripancreatic tissue with no wall formation, and CT severity score is a 6.
Okay. Now there are a couple of questions. What kind of CT is this? Contrast, non-contrast?
Contrast.
How do you know that?
There is enhancement of the surrounding tissues and vessels.
Which vessel is enhancing? You compare it with what? If I just show you a simple CT, how will you say this is a contrast CT or a non-contrast CT?
Vascular enhancement will compare with the bony density, sir. It will be smaller.
Okay, fine. Now you said in your previous slide, your creatinine was 1, right? And things were worsening. You still managed to do a contrast enhanced CT?
Yes, sir.
Okay. Okay, fine. Now, a very, very basic question. How do you diagnose acute pancreatitis? What is the classification?
2 out of the 3 criteria, patient presenting with pain abdomen are related with the symptoms, along with the elevation of their markers, serum amylase or lipase more than the upper third limit. Or if you have any imaging which suggestive of a pancreatitis. Out of these, if we have any 2 features also, we can diagnose an acute pancreatitis.
What is this classification's name?
Revised Atlanta.
Revised Atlanta. Okay. Now you said CT severity score of 6. From where did this score come?
They are like CT severity index. It has depending upon involvement of the pancreas and also necrosis. There is a composite score, necrosis score, and there is a involvement of this pancreatic score. So both will combine and will give you a composite score of 10. They're like 0, 1, 2, 3, and 4. In the pancreas, and the necrosis 0, 2, and 4. So, for in case of no pancreatic necrosis, their score is 0. In case of pancreas more than less than 30%, it is given a score of 2, and more than 30% given a score of
33 to 50% 4, sir. More than 50% score of 6. And
the maximum is what you can get is 10, right?
Yes, sir.
Okay.
So do we believe CT severity index, whatever you are telling, is this the best score, or there are some other simpler scores, or how many scores are there in imaging?
Imaging.
There are a lot of scores. So, and why you are sticking to CT severity score? Is there some reference to that this is better?
There were randomized controlled trials which compared the CT severity scores and the patient outcome along with the other MR imaging scores also. That showed more of the patients with severe acute pancreatitis correlating with the CT severity features. More accurate in diagnosis. The sensitivity is more so.
Okay.
What are the other scores we have in radiological scores?
The
one which we were traditionally taught earlier on, which all our professors used to ask us, which is much simpler for us to use at bedside. I think someone put in the chat Balthazar score.
Balthazar score.
That was the conventionally used score, isn't it? And the CT, the only reason why we have adopted CT severity is because of the study which showed a good negative predictive value. It had a very good negative, but a very poor positive predictive value. But there are so many other different scores in radiological imaging. So there is pancreatic size index, there is extra pancreatic score, extra pancreatic inflammation of CT EPIC score, and modified CT severity. So there's a lot of scores. I think that's not our domain. So we can stick to one of them. CT severity seems to be a reasonable.
Yeah.
Move on.
Next, please.
Between day 47, patient improved clinically, sensorium was better, and tachypnea was settling. Patient is off vasopressor support, and fever spikes were subsided, and ABG was normalized, and patient leukocyte count was improved. Patient initially started on oral liquids as toilet, and later on gradually shifted to soft diet, and patient is shifted out of ICU on day 7.
Okay. Any role of probiotics?
No, sir. Evidence or guidelines do not suggest any role of probiotics.
Okay. In patients who are not, you were not able to feed this patient for a couple of days.
Yes, sir.
Does it have any role, any recent literature, any RCTs which have said that if you can administer probiotics, prebiotics, anything?
No, sir. There is no evidence which is favoring for a probiotic administration.
So see, I agree there is no data which suggests, but there are recent trials which have said that if you're adding prebiotics to these patients who are not tolerating oral feeds, the incidence of intolerance reduces if you're adding prebiotics. But yes, as per the guidelines, there is no relevant recommendation on this. But recent trials have suggested that yes, addition of prebiotics can help in starting the feed earlier in these patients. Okay. You said patient initials are tolerated later on soft diet. Patients shifted out of the ICU.
So
Okay.
this patient
Fine.
is
Sir, the voice is. Sir,
So
the
lot
voice
of
was,
disturbance, sir, Pradeep. Yeah.
voice was cracking, sir.
Oh, voice was cracking. Is it better now?
Yeah. Now it is
Yes.
clear, sir.
No, I was just telling this case is a very straightforward, simple, mild pancreatitis, isn't it? It's not severe because he
Yes.
didn't have end up with any organ failure.
Yes.
He didn't have intra-abdominal hypertension. He did not have an abdominal compartment. So nothing of that sort.
Okay. Can you move on? Is this the last slide?
Yes, sir.
Yes, sir.
Okay. Now suppose this patient, so I'll go out of the purview of the case. Now suppose this patient had gallstones,
Yes, sir.
right? What would have changed in your management?
In the index presentation, we can do a cholecystectomy to prevent the recurrent pancreatitis in this case.
Anything else? Cholecystectomy is too advanced. Anything else?
After the patient has stabilized, sir.
Before cholecystectomy, anything else? What will cholecystectomy do? Okay. What will cholecystectomy? You have already diagnosed pancreatitis.
Yes,
You
sir.
know there are gallstones. What is
Yes.
going to happen with cholecystectomy? What is cholecystectomy going to take care of? Only the gallbladder, right? In
Yes.
cholecystectomy, you are going to take away the gallbladder. That's the whole simple procedure.
Yes.
What about pancreatitis? Why has pancreatitis happened in gallstones? What is the pathophysiology?
Because of the obstruction to the biliary drainage, sir.
So what are you going to do for that?
We-
Anything else? The recommendations also say that, the guidelines say that we can do this procedure.
If patient had biliary cholangitis along with pancreatitis, or if there is any bile duct obstruction, we can go for ERCP, sir.
Yes, ERCP is recommended early in biliary pancreatitis, right?
Yes,
So to
sir.
diagnose that, you can do an MRCP first.
ERCP.
Okay. What about pain relief? Or let us say you did an ERCP and the pancreatitis worsened,
Yes, sir.
right? Is
Yes.
that is a possibility? ERCP induced pancreatitis,
Yeah, sir.
right? Anything specific in pain relief for this? Anything specific?
Epidural analgesia we can consider, sir.
No. So there is a large dose, a bigger dose of rectal NSAID. That is nowadays the recommended pain relief if you are having ERCP induced pancreatitis. Remember it, right? Rectal NSAIDs can be given. Yes, you can give your opioid, but rectal NSAIDs is also a drug is the administration of choice when you're looking at ERCP induced. Okay. So what are the complications of fluid resuscitation in pancreatitis?
Patient results in fluid overload state, sir. He can develop pulmonary edema or he can develop intra-abdominal hypertension.
Okay. How will you diagnose intra-abdominal hypertension?
We have to measure the intra-abdominal pressure, sir. If the intra-abdominal pressure is more than 20 mmHg with the then more than 12 mmHg, then we consider it like an intra-abdominal hypertension, sir.
And how do you diagnose? How do you measure intra-abdominal pressure?
We measure it using a transurethral approach, sir. We place a needle transurethral into our Foley's. After that, we block it and we connect it to a transducer, and then we check for the intra-abdominal pressure, sir.
At what level?
At the pubic iliac crest levels.
What should be the position of the patient?
Flat and
Flat
flat bed, sir.
or semi-recumbent?
Flat bed, sir.
Flat bed. Okay. Do you want to instill any saline into that Foley's and then clamp it, or you don't want to instill any saline?
We instill saline and then we clamp it, sir.
Is it necessary to instill saline? If the
Yes,
patient
sir.
has urine in the bladder, your saline, how much saline do you want to instill? Okay. How much saline do you want to instill?
How much saline?
Okay, fine. What are the clinical findings if your patient has intra-abdominal hypertension?
There will be abdominal distension, sir. More increased worsening of the pain abdomen.
Anything
And-
else?
Decreased perfusion will be there. So when we do an ABG, we can find it, elevated lactates
Anything else?
and organ dysfunction.
Like
There could be decreased urine output, or there could be elevated urea creatinine or blood urea nitrogen levels.
anything else? Can the patient become more tachypneic?
Yeah, more tachypneic and yes,
Why?
sir. Because of the raise in the intra-abdominal pressure, there will be diaphragmatic push will be there, sir. So the patient will be more tachypneic. Increased work of breathing will be.
Okay. Sir,
Yeah, so if you suppose this patient has a high intra-abdominal pressure, and what do you call that? All those organ dysfunction, if it is setting in the setting of raised intra-abdominal pressure, what do you call that condition?
Abdominal compartment syndrome, sir.
Okay, so this patient, considering that you have over-resuscitated, maybe with 30 ml per kg or 20 ml per kg, and he has developed abdominal compartment. So we consider at day 7, you're planning to shift the patient out of ICU. He becomes oliguric, he's becoming short of breath, his PaO to FiO2 ratio is worsening. So how would you now manage this patient with regards to reducing his intra-abdominal hypertension? What are the steps that you will undertake?
Initially, non-surgical or medically, we can consider adding on a diuretic, sir, or we can do a nasogastric decompensation or a rectal decompensation to decrease the intra-abdominal pressures.
Okay. Any other tools you would use? What do you think is the cause for worsening intra-abdominal? One is overfluid resuscitation, but what is the commonest cause of intra-abdominal pancreatitis? Commonest cause, what we see generally.
Overfluid resuscitation is one of the causes.
Yeah, that you said, and you addressed that. What are the
Yes.
other commonest? There is abdominal pathology. There's something happens with the bowels, isn't it? What happens?
Ileus.
Paralytic ileus.
Ileus is the
Ileus.
commonest cause, isn't it? So how would you, suppose considering this patient has had an ileus, so is there any medical tools that we have to address? You said decompression.
Yes, sir.
Anything else that you look at in a basic way?
For
It's a very
diagnosis.
day-to-day, every day we see this, isn't it? Ileus, we try to chase something, then sometimes we use certain drugs.
We give a prokinetics, sir.
Okay.
Electrolytes.
We can give a diuretic, we can give a prokinetic.
Rajesh was mentioning something.
yes.
Electrolyte correction, sir.
Which
Very
electro?
important, isn't it?
Potassium.
Yes.
We have to keep, these are all basics in ICU. We have to keep potassium maybe try to keep it the uppish normal, maybe more than 4. And then we use prokinetics. Then even there is a role for neostigmine we use, and even the recommendation suggests that neostigmine can be used where you have ALS.
Okay, now your patient was not tolerating feeds in the earlier days. What is the role of, let's say, why didn't you think of putting a nasojejunal tube here? Is there any role?
Studies did not show any mortality benefit or any improvements with the nasogastric feeding or a nasojejunal feeding.
Okay, then why everybody wants nasojejunal feed to be started? Is there a scientific rationale behind it?
If the patient is clinically worsening and we are unable to start on the oral feeds and not tolerating persistently nasogastric feed and not needing the total nutritional requirement, then we can consider total caloric requirement.
So if suppose they are not tolerating, would you consider nasogastric they are not tolerating? So would you go for TPN or would you have any other strategy?
We can, if they are not tolerating, but we have to meet the nutritional goals, then we can try for the nasojejunal feeding. If that also they are not tolerating, then we can consider for a total parenteral nutrition.
Okay. Kind of.
I think Sachin, you're logged out, is it? I couldn't see you. Venkat, Sachin, Sachin is here. Did you log out, Sachin? Shashi, I think Sachin must have had audio visual issues.
Net issues, sir, most probably.
Okay.
Internet
I think
issues.
we've come to the end of it. It's almost 1 hour, more than 1 hour. So we'll get Sachin to log in if there's anything.
Now I'm
more
back
we
here.
can-
Yeah.
Sachin.
Sir,
you
I've
logged out.
logged in, but I'm not.
Yeah, that's okay. You can put the video of Sachin.
I'm
Sir, in the total chat box, actually, there are some interesting questions, sir. One is about antibiotics, prophylactic versus our empirical antibiotics. So prophylactic anyway, no role. Empirical antibiotics, timing and decision, how to start and when to start.
Yeah, see, I mean, how much ever you review the literature, there's no role for prophylactic antibiotics or even empiric unless there is a strong reason to believe there is an ongoing infection locally. So obviously that will be determined by your if you have a collection and you are unsure whether it's an infected collection and you're convinced, then you can use other tools like procalcitonin. In fact, they do suggest that procalcitonin could be used as a tool to determine whether there is possibly an infection. So only when there are convincing features to suggest there is infection, you could consider starting antibiotics, but there's definitely no role for preemptively starting antibiotics when the index of suspicion is low. Because now we have advanced tools to determine whether there is infection. So biomarkers is one way, and even if there is collection, radiological intervention to aspirate the fluid and then determining whether it is infected. So that's the way to go rather than jumping and putting everyone on antibiotics.
Next one was complications of acute necrotizing pancreatitis and how to handle the most serious complications. Actually, we have so many audience from Indonesia. They have so many questions. So one among the.
We answered some of them. See, what I suggest is, there is one very good, very recent update on pancreatitis management that has come. I think I can share that article. It's come in current opinions in critical care. You can go through that. So they have suggested that if there is any necrosis, ongoing necrosis, then there is a suggestion to do in a less invasive way rather than in a very invasive way. So rather than going for necrosectomy, so there are clear indications to say when you intervene, when there is a walled off sort of a collection, that is the best time to intervene for minimally invasive sort of an interventions. So and other complications we did address, like you have intra-abdominal hypertension, or and you have to serially prognosticate if they are progressing towards multi-organ dysfunction. With regards to prognostic tools, just confining to pancreatitis, all the scores they have compared, and I'm sure our Lohitha and Rajesh must have gone through. So tell me, Lohit and Rajesh, what is the best tool with regard to evidence in prognosticating the severity and progression of pancreatitis?
Comparing various prediction scores, sir, Apache 2 as well as our BISAP score and Ranson's criteria had better sensitivity, sir.
Yeah, I think Apache, which we are so much used to for all the audience in ICU, which is a generic tool that we use for all our scoring of patients, seems to perform very well compared to other tools. And CT we did discuss. So CT severity index seems to be modified. CT severity index seem to have a good sort of a prognostication. So putting your clinical and imaging tools, prognostication can be done with regards to severity. With regards to intervening for complications, which is the question you asked, Shashi, I think we need to again do some imaging, look for walling off of the collection. That is when intervention is suggested with interventional radiology to do the aspiration of fluid or necrosectomy also only after the walling off of the lesion. In acute pancreatitis, surgical intervention is discouraged. It's not to be encouraged. So this is what the latest consensus has been.
So another interesting
I think
question,
Sachin,
sir.
I think Sachin, we are going through
Prevent-
Viva, so it's good
Yeah.
Sachin came in. So there's a lot of questions
There
from
was
audience.
some internet issue.
Yeah.
Yes. Next is preventive measures to reduce the incidence of pancreatitis.
That is fairly
preventive-
intuitive question. Preventative in this particular patient, if he is obviously ethanol, so he
Ethanol,
has to
yeah.
obviously stop ethanol. And as discussed, if gallbladder calculi is the cause, so we have to treat the cause to prevent the recurrence of pancreatitis. So if it is gallbladder calculi, obviously one has to consider cholecystectomy. The timing has been debated again with regards to the evidence. So there is two schools of thoughts whether you would do early cholecystectomy or late cholecystectomy. The consensus is within 3 months is considered early after you have circumvented with ERCP whatever cholangitis that may be present and drained off the common bile duct. So within 3 months is considered early of cholecystectomy. But in acute stage, I think early cholecystectomy seems to be reasonable after the crisis is after the time of crisis is surpassed. Sachin, your thoughts?
Yes, I agree that so it depends on the stage of pancreatitis, as in the category. If it is an early pancreatitis, gallstone related pancreatitis, then yes, an early cholecystectomy is still warranted. You can go ahead, and generally it is done at the time of the discharge of these patients. But otherwise, you can do an interval cholecystectomy once the patient's symptoms for pancreatitis have settled down, they've started accepting orally well, and then you can plan it and do it. But ERCP should be done as early as possible once you are able to diagnose that there is an obstruction to the flow and there are features of cholangitis which are happening, which your liver function test and other things will let you know that there is rise in bilirubin and GGT and alkaline phosphatase, which will tell you there is an obstructive issue going on. So ERCP should be done early, but cholecystectomy can still take a backseat.
Pertaining to ERCP, sir, one question is risk factors for post-ERCP pancreatitis.
So the person who is doing it is the biggest risk factor, frankly speaking, right? So how confident he is to do it. And see, what happens is once you're doing an ERCP guided procedure, the biggest risk is slipping of the stone and actually getting lodged there. So that is one risk factor where patients can have ERCP induced pancreatitis specifically in these cases. But otherwise, other than that, I don't see any major risk factor per se. right? So it also depends on the number of stones that have dislodged and what is the location of the stone. More distal stones are more difficult to, both to tackle and then to put a stent there. So it also depends on what stage you are doing ERCP in these patients.
Another question is, what causes of hypercalcemia can lead to pancreatitis?
What levels?
What causes of hypercalcemia? Hypercalcemia causes pancreatitis. What are the various causes which can cause hypercalcemia that lead to pancreatitis? That is maybe.
So any cause which can lead to hypercalcemia, malignancy induced hypercalcemia is there, right? You can have myeloma induced hypercalcemia. So multiple myeloma induced, right? So any causes which leads to hypercalcemia can also lead to pancreatitis.
Another question,
Not to
sir,
forget, there
regarding-
are hyperparathyroidism who present
Yes,
with recurrent
adenoma.
calcific pancreatitis. So that is also something which is very commonly we see who have hyperparathyroidism and calcific recurrent pancreatitis. So that also need to be kept in mind.
And we discussed a lot about the fluid resuscitation, sir. And there is one question regarding de-resuscitation. When to start de-resuscitation, whether it is required or not, and how we will decide on de-resuscitation.
So see, we always should understand when to stop resuscitation. So yes, early aggressive resuscitation is not the right word. It should be a personalized resuscitation, patient dependent resuscitation. But once you start seeing features or side effects of this resuscitation in terms of increase in the ascites, let us say increase in the free fluid in the abdomen, right? You start seeing patients becoming more tachypneic, and there are features that the patient's oxygen requirement is increasing. Patient's abdominal distension is increasing. Patient is showing signs of other organ dysfunctions. So that is the time when your fluid resuscitation has crossed its safer limits and you will require resuscitation. Now, de-resuscitation will also depend on what is the renal status of this patient. Now, suppose this patient also has an acute kidney injury and is not able to produce adequate urine, you need to decongest these patients. Then an early renal replacement therapy has to be instituted. Otherwise, these patients will have secondary problems because of the fluid issue. So de-resuscitation should be started once you start seeing the adverse effects of your resuscitation. But this aggressive resuscitation should not go on for days together. Generally, first 2 to 3 days in acute pancreatitis is the enough time frame. Now, this is a practical aspect that I'm saying. I don't know whether any guidelines suggested, but that is the acceptable time frame where you will have done your adequate resuscitation. Sir, you want to add something?
Yeah, I mean, Sachin is right. See, I think we know intuitively that all the evidence, there are multiple studies on de-resuscitation that has happened, and they have taken all mixed cohort of patients. So by day 3, we have to try to, once stabilization has happened of whatever primary problem that we are dealing with, one should at least have this in back of mind that we don't want to continue waterlogging the patient, and you have to look at re-resuscitation at some start. Day 3, net neutral balance is what all the studies say is safe, and by day 7, they should be supplemented in negative. One is in acute pancreatitis, once your optimization of fluid status is acute, and if you believe that patient is stabilized, then possibly you can look at least a net neutral balance at some stage. So that should be a reasonable goal. Obviously, if patient is continuing to be sick, then you have to continue using your goals to see what sort of a resuscitation goals that you have and try to attain that. But at day 3, I would agree that we have to start contemplating on de-resuscitation at some stage once stabilization is achieved.
Yes. Another question, sir. Drugs that are contraindicated in pancreatitis. And one more question was interaction of opioid analgesics with insulin.
So the drugs causing pancreatitis.
That's a huge list.
That's a huge list, but steroids are commoner and yeah, so a lot of drugs. But I think steroids possibly the commoner ones, and azathioprine can cause So many drugs are there. Chemotherapy drugs can cause.
Hydrochlorothiazide can cause it. So there are a list of drugs,
So those are the few questions which are looking good, sir. The rest of the things we have discussed.
Okay.
Any final comments or suggestions, sir? Pradeep sir and Sachin sir?
I would say this was a very straightforward. It was not a very complicated case, Shashi, because it had a very smooth sort of a transition. But this patient possibly would not remain in ICU for very long. So the typical cases we see in ICU are someone who comes with multi-organ dysfunction and who have acute kidney injury, who are on dialysis, who have abdominal compartment, they are intubated, ventilated. These are the complicated cases we tend to generally see in ICU. And there'll be a lot of confounding factors with regards to ascertaining the severity. And generally, these are the cases. And another thing which possibly we didn't touch about is whether there is a role for any extracorporeal benefits with certain usage. Even so, that is something people use. So there's no strong evidence for using any medical therapy. But when we are pushed to desperation, we do consider extracorporeal like cytosorbs, so on and so forth in these situations. So this is a very mild sort of a pancreatitis run of the mill. So we did not end into any complications. But the tenets of managing any pancreatitis is having a good conceptual understanding of good ICU care, because good fluid management, good analgesia, and early nutrition, and using antibiotics only when it is needed, and watching out for any complications and looking for the trends of any progression of pancreatitis, and doing minimally invasive procedures to address the complications at a time that is appropriate, not early, not too late. And this will happen in consensus with our gastroenterology friends. I think that would be my submission.
Yeah, I agree to what Sarah said, and just one more point that once if there is a severe pancreatitis and you start seeing collections in week 2, week 3, then you start putting these percutaneous drains, and they are now recommended, and you don't just push these patients for surgery. So you're basically doing a medical necrosectomy kind of thing, and which are recommended to push your patients as far as possible, and you're trying to push them to at least week 4 or week 5 by the time the necrosis and the inflammatory process has settled down to a certain extent, and you start seeing a pseudocyst formation. So the plan is to delay the surgery as far as possible, and all these complications can be managed by percutaneous drains. You can have I would say we land up putting 4 drains, 5 drains. The whole purpose is drain the collection if it is infected, right, and try to delay the surgery if it has to be done as far as possible, or eventually any endoscopic procedure can also be done. But early feeding, good intensive care, limitation of resuscitation should always, you should be aware, you just do not continue giving fluids to these patients, and de-resuscitation should be started by day 3, day 4, as in try to maintain an equivalence.
I think just to add the new things to be considered, which possibly may be useful for all our attendees is, yeah, there is some evidence that tried to use, maybe consider ringer lactate as opposed to saline in pancreatitis, because there is some evidence. Analgesia, as Sachin said, use the epidural, which is also good. Don't delay usage of epidural, which we use routinely in our practice. And use intrathecal, which is also something which we don't use that often, because there is now good Chinese trial or something that's come. We show some good sort of evidence. And early ERCP, and I think there is some suggestion that PD stents to be placed to prevent, because I see a question how to prevent ERCP-induced pancreatitis. There is some suggestion of placing the PD stent to prevent, sort of a worsening of the ERCP-induced pancreatitis. So these are some new things that I could gather, and there is sort of suggestion if you are really things are worsening, the inflammatory cascade is getting perpetuated. So extracorporeal can be considered as a desperate measure, cytosorb in small anecdotal reports. So this is ulinastatin. Someone has asked. I don't know. There is no robust evidence. It's not come out in guidelines. But Sachin, your thoughts on that? And these are some of the newer things I could add to this.
So, sir, ulinastatin, there have been anecdotal reports about, using ulinastatin in severe acute pancreatitis, but still not a part of the routine management.
I think we have covered almost everything about the pancreatitis, sir. Thanks, Pradeep sir and Sachin sir for your
So
valuable time and
congratulations to
knowledge.
Lohit and Rajesh. I'm sure they have done enough and more reading, so they could pick on me and Sachin on few
Actually,
of the nitty-gritties.
No, but
yeah,
well presented
they have
and
presented in very short notice, sir.
Okay,
They
and
have
good luck
presented in
to
very
both
short
of you.
notice, sir.
And good luck
Yeah.
to both of you presenters.
Thank you, sir.
Thank
Thank you,
Thank
everyone.
you,
for
Sachin.
participation.
So
thank you.
look forward to meeting you soon sometime in person, Sachin.
Yes, sir. Yes, sir. Thank you,
Take
sir.
care.
Yeah.
Okay, good night. all of
Bye.
you.
Bye, sir. Bye.
Yeah.
Thank you, Dr.
We will
Venkat.
close the session.
Thank you. Yeah, bye. Thank you, Dr.
Venkat has
Shashidhar.
disappeared, I think. So thanks, Venkat.
Venkat.
Thanks, Shashi, for coordinating.
Thank you, sir.
Okay. Bye. Bye.
Pawan, we will close the session. Thank you, everyone.